And good evening, everybody. Dr. Bill Tulo, Chief Medical Officer at Oculus Inc. And I'm excited tonight to have a really great speaker, Dr. Shane Swatts, talk to us about mastering IPL implementation. Dr. Shane Swatts originally was from Princeton, West Virginia, pursued his studies in pharmacology and toxicology at West Virginia University before earning his doctorate degree from the Pennsylvania College of Optometry at Salus University. He's a dedicated member of the American Optometric Association and the Virginia Optometric Association, the Tidewater Optometric Society, and the American Academy of Orthokeratology and Myopia Control. After completing his optometry degree, Dr. Swatch honed his expertise at the esteemed Vision and Conceptual Developmental Center in Washington, D.C. There, he specialized in sports vision training, collaborating with the National Football League, and conducting rigorous vision and perceptual testing for professional athletes in England. Dr. Swat's practices focuses on the advanced treatment of ocular surface disease and facial wellness aesthetics. He's frequently featured in national publications on eye care and dry eye disease. Dr. Swatts is the owner and operator of Eastern Virginia Eye Associates in Chesapeake, Virginia, and a co-founder of OD Immersions, which you'll hear more about tonight, providing dry eye implementation training and consulting services to doctors across the United States. If you have any questions as we go along, please place them in the chat. But with no further ado, Dr. Shane Swatts, take it away.
Thanks, Bill. I appreciate you guys having me tonight. So thank you to Oculus. I'm excited to talk about implementation, which I think is a very um, not talked about topic as it relates to some of these advanced devices. So we're going to jump right into it, have a lot of information to cover. Um, Common buzzword that we hear these days in the dry space is multifactorial. And what I've come to learn is multifactorial basically means complex and often confusing. So there are so many moving parts when it comes to not only diagnosis, but diagnostic technology, treatment technology, pipeline medications. There's a lot that goes into this. And so while that multifactorial word is important, my goal today is to minimize some of this complexity, some of this confusion, and really it will share some information on how to implement these devices and make them work for your particular office. We're going to run through some quick stats on dry eye. You guys are familiar with most of these, but I want to point them out. 49 million plus Americans suffering with dry eyes. An overwhelming majority of them are related to the quality of tear. So we're talking about meibomian gland dysfunction. And then a smaller percentage, of course, are going to be the aqueous deficient. We, as part of OD Immersion, have pulled doctors we work with across the country. We've looked at studies, we've used AI to figure this stuff out. But if we look at the most common barriers to either doctors implementing or doctors bringing in this technology, or once they bring it in, what are the barriers to them implementing this technology? This is it. This is what it boils down to. So let's walk through these quickly, and then we're going to move on into some detailed information. So cost and financial concerns. There is an initial investment required to adopt these new technologies. I mean, we're looking at anywhere between, 30,000 to 150,000 on some of these devices. And what I'll say is when it comes to this initial investment, as it relates to IPL and some of these advanced treatments, it is the one part of your practice where you do not want to go to, I'll use the word cheap here. You don't want to go too cheap on the technology. And I'll give you an example. I just had a call from a ophthalmologist in Dubai, and she reached out and she said, "Hey, I want to do aesthetics." I was like, "That's awesome. Let's talk about it. What device do you have?" And I'm not going to name the device, but what I came to learn is the max energy level on her device was 13 fluents. Now, if you have an IPL, you know you can do dry eyes with 13 fluents, but you can treat zero aesthetics with that energy level. And so, the end result of that conversation is, I'm happy to help you. You need to go get a new device if you really want to move into this space. And a lot of docs aren't familiar with the differences in devices. But one thing I want to make clear is not all IPL devices are created equally. There is some uncertainty about profitability. There's a lack of experience in monetizing these technologies. And what that means is eye doctors are often not accustomed to discussing cash pay treatments. And I'm one of those. My background, I used to do a whole lot of primary care. Now I only do dry eye. And back in the days, I did primary care. I was that doctor who would go and get their front desk person to come into the room to talk to an angry patient about a $10 copay. So now I have no problem presenting a 2,500 dry eye treatment, but there are techniques and strategies for doing so. So this lack of experience can easily be overcome. Let's go to the lack of knowledge and training. We get this question a lot. Where do I find training for this? Typically when you get a device, you get about, excuse me, you get typically about 6 to 8 hours with a trainer. And that's great. The tough part is you really don't even know what to ask at that visit. You don't know what you don't know. It's not until a month, 2 months, 3 months pass that you actually get a better understanding of what are the relevant questions that I need to ask. So, although training initially is beautiful, what often happens is the doctor implementing this technology 2, 3, 4 months later really has no one to reach out to. And we're going to go over some of who they often reach out to in those cases. And we also have the complexity of integrating new technologies into workflows, right? We're all busy. So when a doctor brings in these devices, excuse me, oftentimes they are trying to implement this technology in their downtime. And if you want this to be successful, it is not a technology that you can do when you're not seeing patients. This needs to be something that really gets momentum going in the beginning. Lastly, let's look at patient demand and acceptance. There's, some docs we talk to that their impression is, I'm not sure I even have the patience for this. Like, do I have the patient demand? We're going to address this as we go, but the demand is definitely there. We also have the fear of being seen as a salesperson. This is a big fear. This is not only optometry, this is also ophthalmology, this is dermatology, this is in a lot of fields. And I learned this from lecturing in the world of aesthetics and actually having some of these dermatologists come up to me after a lecture saying, hey, how do you go about charging a patient that much? And my question, yeah, I was shocked at this. I'm like, well, aren't you guys the one charging a lot of money? So it's not only ODs, it is ODs, MDs, and it's anytime you're offering a cash pay treatment, there's that kind of fear in the back of your mind. So let's keep going here. As far as addressing patient demand, if you look at the diagram here, what you're going to see is we all have these patients sitting in our chair. So, when you implement some of these technologies, is marketing important? Initially, no. As you begin it and you keep going, yes. But if we look at all of these different conditions contributing to ocular surface disease, we have them in our chair. If you look at them carefully, you'll realize a lot of these are chronic and progressive, with the exception of contact lenses. Um, let's talk about how we've done so far or in the past using traditional drugs and drops with treating dry eye. Some of the statistics out there are 80% of patients are unhappy with their current treatment, do not feel like it's working. 82% of patients wish there was something more effective that was available for their dry eye. And I think the most important one here is it takes an average of 3.2 different offices. This is not office visits at the same practice. This is a patient jumping from office to office 3.2 times before they find relief for their dry eye. Very important there. Now, if we look at current resources for training, we have weekend boot camps you can go to. Those are great. We strongly encourage people to go to those. What you still have to consider is that whatever the doctor learns at this boot camp, which oftentimes is kind of like drinking through a fire hose, it is up to the doctor to then bring that back and implement what they learned into the office, which is really probably the toughest part. We have social media. There's a lot of social media sites now that you can go to, Facebook sites, Instagram sites that are, dedicated to IPL. What I'll say is be cautious with the advice that you get there. Not that it's bad advice, but unless you have the same piece of equipment that follows the same protocols as the person that you're conversing with online, you're going to get some conflicting information. And so that contributes to a lot of the confusion that's out there as it relates to IPL and RF and some of these other things. Reps are great. They're an amazing resource, but are they going to be the person that you want to contact 4, 5, 6 months down the road when you actually have some real questions? Well, they're going to be available, right? But are they going to have the answers that you need and the detail that you need? Probably not. And then, of course, colleagues. If you have some colleagues that are using the same equipment, using and getting results profitable, then of course go with that. My point with this is that there is significant variability in the information out there. And this was part of the reason ODI was born, OD Immersion was born, is we realized the need for consistent, reliable training. So today, we're going to jump into some of the business of dry eye. So we're not going to cover too much on pulse train and pulse delay and fluence and contraindications. We're going to jump more into how to really make this work in your office, at what top performing practices are doing, and some of the really important pieces that you need to consider, whether you're considering bringing in a device and entering the dry eye space or whether you already have it. So let's start with financial targets. Important one. And what I'm going to do is talk about a sample practice here. So this is going to give you an idea of how many patients you need to see to actually be profitable with these devices. So this is one of the first things we do with docs whenever they come on, is set a target for them. So let's say on a monthly basis, your practice sees 200 patients a month. And I'm using this as an example. You might be seeing 800, you might be seeing 50, but let's say you're seeing 200. Well, let's assume only a third of those patients, so that would be a little over 65 of those patients, actually have dry eye. That is grossly underestimated. We know it's probably more like 70, 80%, but let's say only a third of those patients have dry eye. You then present advanced treatment options and office therapy, which would be IPL, to those 66, and only 10% of them actually accept your treatment. They want to move forward with your treatment. Your target out of those 200 patients is 7. So the idea that you need to have a lot of people moving into this or going into a treatment plan, in-office treatment plan, to be successful is inaccurate. You really don't need many for this to be successful. And let's look at some numbers that support that. So let's say that you convert only 7 of those patients into a treatment plan. Well, on a monthly basis, that would bring in $11,200. And if you look at the bottom right-hand corner, you're going to see this is based on a very conservative $1,600 package. Annually, if you only do 7 patients per month, that would be $134,400. So the numbers work with this. Now, what's not considered in this is, what did you pay for the equipment? What is your monthly payment? Some of those things. And those are numbers you can work through. This is a quick and easy way for you to figure out, based on the number of annual exams you do in a month, how many patients would I need to convert? So you have some idea of what that looks like. Now, when we add RF to the equation, that package price goes up to about $2,200, and you can see those numbers go much higher. So is this something that is realistically possible in most practices? Yes, absolutely. Is the ROI there? It really is, without having to convert, is the word that we often use, many patients into a program. So let's talk now about some of the top performing practices and some of the methods that they use to actually capture patients. And I use the word capture, and maybe I should use the word educate. What we want to get through to the patient is that you have a problem, we have a solution, and explaining that in words and language that they understand is important. The first step to that process is screening. So docs across the country, the most top performing practices do 2 things. Number 1 is validated symptom survey. So you're screening questionnaires. It doesn't really matter what it is. It's SPEED, DEQ5, OSDI, CDERFs, however you want to present it. We strongly recommend a validated symptom survey. Now, we do work with doctors who say, yeah, I think it's too much paperwork. My techs ask about dry when they go in the room. I go in and ask. I can tell you it is not nearly as effective and the outcomes in terms of patients converting is not nearly as high when you are using your own words as opposed to using a validated symptom survey. These also can be used to kind of gauge where they're at in treatment. Number two on the list, the two most important things, validated symptom survey and mybography. Mybography comes in all shapes and sizes and forms, right? We have the ones that will only show you the glands, and you can pull that up on a screen and explain it to a patient. And then we have the mybographers who have great patient-facing software, meaning you're taking them through a story. You have all this data that you now have to work with and can really talk to the patient about it. It also will reveal those asymptomatic patients that are at risk. So maybe they don't need IPL right now. Maybe they don't need advanced treatment right now, but you see some signs that that may be needed in the future. You can go ahead and plant that seed and start talking, let them know that this technology is here and it may be needed in the future. Very, very, very important. Now, if we look at mybographers, I had last year, I believe I had 6 mybographers in my office. So I have a lot of experience with mybographers. Nobody needs that many. But what I'll say is, and I'm not going to name the ones that I had, but I will tell you when I brought in the 5M, it really changed the dynamic of my practice in terms of diagnosis, in terms of my eval time. My eval times used to be 45 minutes, sometimes even longer, because I was gathering all this information. I was showing them one thing, going to a different program, showing them something else. This has allowed me to really do all the diagnostic testing that I need on a given patient in a short period of time with reliability, and then be able to present it to them as a story. And when I say a story, here's what I mean. I have this up in a room and I can go through, hey, this is your redness scale. Here's what it's related to. Here's your mybography. I can pull up then a screen that compares the mybography to mild, moderate, severe. I can go into, going back to this one, this is related to oils. What happens if you don't have a good oil layer is your tears are going to evaporate. Here's your tear breakup time. So it flows really easily. Here's your quality of your oils. It allows you to customize the tests that you feel are important and present those to the patient in a very simple fashion. There's a beautiful dry report that comes out at the end. I'm not going to get into great detail there, but let's talk about some of the hurdles. So time, one of the top concerns about adding mybography and sometimes even a validated symptom survey is the time. The additional time it's going to take the patient to fill out the paperwork, the additional time it's going to take to actually do the mybography. I can tell you it is worth it from a couple perspectives. Number one, you implement this into your practice and you're doing something different the patient hasn't had before. And you're doing something that most doctors they may have seen or doctors that they do see are not doing. So you're immediately elevated in the patient's mind in terms of the technology that you have. Let's look at patient flow. So there's the concern of the machines are taking too much time. They're holding up our pre-testing area. It turns into a backlog of patients waiting to get into that area. That can be true. And so there are mybographers that are great to have for pre-testing. There's mybographers that are great to have for your full dry evaluation. And then lastly, there's always the concern about skill levels. A lot of doctors feel that you have to flip the upper lids on every patient they do mybography on. I will tell you when this is used as a screening tool, what we found is that you can gain a lot of valuable information from simply doing the lower lids. So in our clinic, we have our staff as part of the workup, just like they do auto refraction, just like they do IOPs, they are getting mybography. And pulling down the lower lids is not complex. Patients accept it well. And so skill level with a little bit of training is really not a huge concern. But those are some of the common obstacles or feedback that we get from docs on doing that. And let's look at some clinical models and scheduling. Two main clinical models. There are, much like you would do for a glaucoma suspect patient. You do a comprehensive exam, you identify this patient as a glaucoma suspect. What are you going to do? You're going to bring them back for OCT and visual field and what other testing that you may want to do. Well, same concept. In that first visit, you're not going into extensive detail about glaucoma. You're going to do that when you bring them back for their glaucoma eval. So, bringing patients back for a dry eval allows you to mention it at the comprehensive exam, show them their glands, let them know you have concerns, but really dive deeper into it at the dry eval. Now, there are some doctors out there who have the language and have the flow. My consulting partner is one of these. Her name's Dr. Garcia. She does this directly from her comprehensive exam. Her exams are a little bit longer, so she has time to do that. What we found is that if your comprehensive exam time is between about 15 and 30 minutes, the chances that you're going to be able to educate that patient enough, get through to them the real concerns that you have, and get through to them the solution that you have is going to be difficult. So in those cases, we do recommend bringing them back for a dry eval. Scheduling considerations are really important. One thing you have to remember is for every treatment package that you sign a patient up for, and we're going to get into more detail about what treatment package means here in just a minute if you're not familiar with it. But when you sign up a patient for a dry in-office treatment package, you got a minimum of 4 additional appointments that they need to come in for. Where are you going to fit those? So that sometimes is very difficult. And so what we found is that there's a couple options. If you have the luxury of having a separate dry schedule, that's great. Most of the time when people are starting off, they don't. So these patients are being mixed into their normal workday. And the big dilemma is, where do I put them? Do I put them do I make a specific dry eye day? Do I make a specific half a day for dry eye? And the answer to that would be no for various reasons. But what I'll say is the best time to schedule these patients for evals and for treatments are last appointment of the morning, last appointment of the afternoon. As you become busier, you start taking that next to last appointment of the morning and next to last appointment of the afternoon. And eventually you get to the point where maybe you do need a full dry schedule, which is a great problem to have. But again, keep in mind, for every patient that you sign up, you're going to need an additional 4 to 5, sometimes even more appointment spots for that, depending on what your protocol is. It is very nice to have a dedicated, you can call them whatever you want, a dry coordinator, a dry liaison in your office who is really staying on top of the schedule and on top of communication with patients, because it almost turns into a clinic within a clinic. Once you start getting deep into the dry space. Now let's talk about pricing and packaging. There's a lot of confusion here, and some doctors, especially the ones who are not comfortable with presenting cash pay treatments, will oftentimes say to patients, we're charging $400 for IPL. Why don't you come in and have one done? We strongly encourage anybody who's doing this now or who's thinking about bringing this in to not allow pay per treatment. And the main reason is, if a patient comes in and has IPL done one time, they want results, right? That's what they're looking for. And the chances that they're going to get any benefit, symptomatic improvement, symptomatic benefit from that one treatment is very minimal. I mean, we're working with a complex disease process. Oftentimes, it's not until around the 3rd, 4th, 5th, 6th treatment that patients kind of turn a corner. So that patient comes in, you allow them to pay for that visit, chances they're coming back is very low. So what we want to do is talk about packaging. We package the treatment sessions. We're going to get into how you do that in just a moment. Now, let's look at national averages. National averages for IPL, I'm going to focus on IPL here, is around 4 to 450. So there is a sweet spot when you look at packaging IPL where we see a higher rate of patient acceptance. And that's right around the $1,600 mark when we're talking about just IPL. It's around the $2,200 mark when we're talking about IPL and RF combined. So, if you're doing this now, look at your prices. One of the things I really hate to see, and I see this a lot on social, is docs not getting many conversions. So what they start doing is lowering their price. And it kind of dilutes the entire industry at a certain point. So, keep in mind, and we hear this over and over and over again, you're providing a valuable service and you need to be paid for your services. So if patients aren't willing to pay that price, it doesn't mean lower your prices. It means let's work on how you're presenting this to the patient. Let's work on touching on their pain points. Let's work on the value and the outcomes that this patient is going to receive from this service. So there's also the option of customized treatment packages versus set treatment packages. Now, the difference in those two are many people, I did this initially. I actually brought my IPL in and I hired a packaging company. It's a company who all they do is create packages for services, professional medical services. It got really confusing because we ended up having something like 8 different packages. The staff had a hard time remembering what they were. We had them printed out. Patients didn't know what they were. So we developed a system that allows for customized treatment packages. And basically what we're doing is instead of fitting a patient into a package, instead you're customizing a package around the patient's needs. And that is always what we want to do. So if we look at some communication forms, now everybody who is part of OD Immersion, we customize these forms to their practice. It's their logo, it's their colors, it's their branding, their brand kit. But let's look at one of these. So this is called our treatment plan estimate. And basically, this is a simple way for you to customize a treatment package around a patient's needs. It's a very simple form. So if we click on this, we'll see here's all my in-office treatments. So I can do, let's say we need 4 IPLs. Let's say we also need to have 2 RFs. Well, that's all the in-office treatments. We can close that. Now let's look at home-based treatments. And this is important because what we don't want to do is tell a patient that their treatment is going to be $1,600, have them get to the front desk, and then say, oh, you also need your home therapy, you need artificial tears, you need nutraceuticals, you need cleansers. So we include everything into a package because otherwise we feel like we're kind of, me personally, feel like I'm nickeling and diming the patient. And I do not want to be seen as somebody who does that. So we include home therapy as well. So let's say we're going to give them a bottle of Oasis, we'll give them some Avenova, we'll give them some nutraceuticals. And what you see here is our total treatment plan price. Now, the patient is not seeing this. This is something that a technician will do in the room while I'm in the room talking to a patient. They'll figure this out on an iPad. And this is the beautiful part, is I don't like to talk about the money. So the patient has heard me create this plan in real time in front of them. And now I can, to a certain extent, exit the room, and my technician, who's much more comfortable talking about money, now takes over. So here's the total treatment plan price. And we have a couple options. If they pay in full that day, they get this much off. It's a 10%, and we adjust this. Some practices want 20%, some practices want 5%, but they can see their total fee right there. If they decide to pay over time, so we do have an installment option. It is not a pay per treatment. They pay half at the first visit, half at the third visit, but the price then remains the same, but they don't get a discount on that. And recently, I'm going to go over this in a minute, we have also included some of these pay over time options that you may be familiar with, Affirm, Klarna, Link, into this. But when you hit the submit button, a very nicely formatted email goes to the patient, and they are then able to see what your treatment recommendation was right away. They know it's customized to them, so it works really well. And that takes all of about 30 seconds to do in the exam room. The other form that we have is a patient education form. And when I first brought in some of this technology, patients were leaving my office with 10 different brochures. Here's a brochure on Hydro Eye. Here's a brochure on IPL. Here's a brochure on everything. And I wanted it to be more customized than that. So this is our education form. So what happens is you click on whatever condition they have. Let's say they have meibomian gland dysfunction and rosacea. Automatically, the language that you want that patient to know is there. Let's get down to our office-based treatments. We're going to do some IPL, and let's do a ZEST treatment. Language that you need is already there. Let's get down to home therapy. Everyone has different home therapy and oftentimes multiple versions of the same thing. So for example, when I click on nutritional, you'll see I have Hydro Eye and I have Eye Promise. I choose the one I want to use. I'm going to tell them how to use it, and I'm going to tell them the why behind it. After I've done all of this, which again takes very little time once you're accustomed to it, I hit submit. The patient then gets a very nicely formatted email that tells them their condition, tells them what I'm recommending for the home-based treatment, for the office-based treatment options, what those are about, as well as exactly how to use their home therapy and the reasons why. Oftentimes, patients want to know the reason why they're using these things. So these are two forms that we've developed that are very powerful. Um, and all of our docs who are part of ODI are using these now, and it's part of the program. It's really been integrated. An important part to dry eye is your home therapy. Some docs will argue that artificial tears are really not worth it. I don't disagree, but I think it is important for the patient to have this around. So there's a couple things I want to talk about on this slide. When we break down home therapy, we break it down into heat, hygiene, health, and hydrate. And we tell our docs, look, you don't have to have all of the various products out there because there's so many to choose from. Choose one from each category. That is what is going to allow your patient to um, have some longevity to the investment they made to the in-office treatments. And repeatedly, what we see are the patients who are consistent with their home therapy. When we follow up 3, 6 months post-treatment, they are the ones that are oftentimes remaining symptom-free, as opposed to the ones who drop everything as soon as you're done with treatment. So we stress home therapy. We have home therapy kits that we've made that we mostly use in primary care. But if you look over here on the left, you'll see a bag in the background. Everybody loves Lululemon bags and tends to not throw them away. So we made a design and contacted a company who makes bags that are very similar to Lululemon. They're great for marketing, but we've combined everything that you see there into this kit. So our primary care doctors, if they want to get somebody started on home therapy, maybe they're not ready for advanced in-office treatment, we have a simple way to provide everything that they need at one stop, and it's for a really, really discounted price. So if you added all this up together, I think this is like $99. It's really not very expensive. So we have patients walking out the door daily with these kits. We have a hard time keeping inventory because they're walking out so quickly. But having some type of home therapy kit is important. And look, it doesn't need to be confusing. Keep the 4 H's in mind: heat, hygiene, health, hydrate. If you're a practice that has zero home therapy right now and you're confused about what to get, it doesn't have to be the products I have listed here, but choose one from each of those 4 categories and you have all your bases covered. Let's get into maintenance. So, oftentimes when doctors are getting into IPL, what we're often talking about is how many initial sessions do you need, right? And there's various protocols out there depending on the device you have. And again, all these devices are different. I would say as a general standard, the initial treatment protocol calls for 4 IPL sessions. And a lot of reps out there, a lot of doctors out there are under the impression that you do those 4 sessions and then you bring them back for maybe a 6 month refresher or an annual IPL just to keep things rolling. What I'll tell you is that we have a slightly different thought on that. Our maintenance is either monthly maintenance or quarterly maintenance. Now, monthly maintenance, these are for those people who are moderate to severe dry eye, who maybe had some improvement on those first 4 sessions, but they need more. That's one category that falls into this. Another category that falls into this are those patients who responded pretty well to the initial 4 sessions. They also noticed the pleasant side effect of it having an aesthetic benefit, and they just want more aesthetics. And so we have these patients sign up for monthly maintenance. They come in once a month and they get one treatment session. We have various devices, so we can choose whether to do IPL, RF, LLLT, Zest, whatever we may do. But it allows us to see them on a regular basis. These are my patients they've forgotten about their dry eye. Their dry eye is no longer a problem. They're in our office monthly. They're the ones that are buying skincare. They're the ones buying more glasses. They're the ones ordering their contacts through us. So in doing this, there are these other revenue streams that you may not see or capitalize on if these patients are coming back only 6 months later or a year later. Now, something important that I personally tell every patient I see is that everyone requires maintenance. We break we break treatment into basically two components. There's the initial, what we call rehabilitation phase of treatment. That's where we do these first 4 sessions. And everyone's going to respond a little bit differently. And I want to stay on this slide for a minute to talk about this because there is some confusion out there as well among doctors as far as does IPL work? Well, that's where we were about 4 to 5 years ago, right? When I brought this in, I was like, okay, does this stuff work? We're at the stage now where we know it works. What determines how quickly it works is that patient's entering severity level. Meaning, when you have a patient sitting across from you, you're at a dry eval, and this is a 57-year-old female post LASIK autoimmune contact lens wearer, they are severe. They're automatically severe in my book. So what I tell them is these first 4 sessions are going to move the needle a little bit. They're going to get you headed in the right direction. But I anticipate after only 4 sessions, you're probably not going to have much symptomatic relief. And this is where some docs go wrong in terms of their recommendation. They're not quite as transparent with the patient initially. So for your severe patients, those first 4 sessions are going to get them moving in the right direction, but expect that they're going to need maintenance. I didn't know this in the beginning. So my language initially, when I first started doing the IPL years ago, was, yeah, let's do these 4 sessions. You're going to be golden. All your symptoms are going to be gone. And it caused me to have a lot of really uncomfortable conversations at their follow-up visit because they weren't better. And it was only through doing this that I learned there are those patients, your initial grading of their severity level is very important. If they have mild MGD, no telangiectasia, no contributing systemic history, yeah, 4 sessions are probably going to do the trick. Most of the patients, when you start getting deep into dry eye, are going to be more of the train wrecks, right? You're going to get those patients that are simple, but you're also going to get sent these really complex patients. So letting the patient know this right from the beginning, setting those expectations is really, really, really important. And also making sure your expectations are aligned with the patient's. And what I mean by that is, as a doctor, we're looking at a patient, and in our mind, what we're thinking is, okay, I need to get rid of the keratitis, I need to get rid of the biofilm, I need to open up the glands. Well, what does the patient want? They don't even know what that stuff means, right? So what does the patient want? They want to wear their contact lenses longer. They want to not tear all the time. They want to minimize the light sensitivity. So you have to align your expectations with the patient's expectations so that you're both on the same page. We go as far as creating treatment goals for our patients. So at the dry eval, our technicians are trained to find out in their own words, in simple terms, what to that patient looks like a successful treatment. And you'd be surprised at some of the responses we get. For some patients, it's as simple as, I want to stop tearing as much. Okay, great. We write that down in the chart. Every time we see them for an IPL session, we don't go in and say, how's the dry eye? Because that's a way open-ended question. We go in and say, how's the tearing? We then document that in the chart. So as we're going through these treatment sessions, we can gauge how we're doing. What does that follow-up session look like where we're talking about maintenance? So expectations are important. I probably should have done a whole section on that, but it just came to mind. Another thing that we've recently implemented for monthly maintenance and quarterly maintenance, as well as for patients initially signing up, if you look down here in the right-hand corner, is pay over time. Patients can now sign up for this, and using something like Affirm or Klarna or Link, immediately they can see how much they're going to need to pay per month. Now, we get all that money up front, and it's now up to them and the company that they went through to figure that out. But this is something we've introduced into our optical, something we've introduced into all of our advanced services, or our dry services, our myopia management services, and it's gone very, very well so far. All it takes is a QR code, and you setting this up in the background, patient scans a code, you put the amount in, the rest is up to them to figure out in terms of what payment schedule they want to be on. But oftentimes you'll get 4 to 6 months of interest-free payments. So this is something that's really great in optical as well. The other option we have is quarterly maintenance. And so these are for those patients who did pretty well during their first 4 sessions, and they're just scared to go back to where they were. They don't want to go back to having those symptoms that they had before. So we have them come in quarterly. When they come in, we do a treatment session and then we express. But these are, again, severity level, how compliant are they with their home therapy, what was their response to initial treatment. All these things are important. Let's get into now a little bit about OD Immersion. And let me just check. Okay, good. So we're doing well on time. So again, OD Immersion was really born out of our noticing the need to create a simplified process for adding specialty ocular surface disease and aesthetics to primary care practices. That's it. We used to take calls with doctors from all over the country as KOLs, and we started noticing the same questions, the same theme, and it all revolved around not necessarily what device they had, not necessarily what company they chose to go with, but how do I make this work once I get it in my office? I'm busy. I don't have time to do this. I don't know how to train my team. My doctors, three of them are uninterested. One of them is interested. How do I do this? And so that's really why ODI was born. It was really born out of a passion project that turned into more. So if you look at our team, these are all the people we have on our team. We have private practice owners, certified aesthetic trainers, technicians, administrators, PAs, NPs, injectors, estheticians, digital communication specialists, all the way down to medical directors. So the people who are interested in doing aesthetics, if they can't find a medical director and they need one, we have that at our disposal. So what we've done is try to create a full system where if you need something in the dry or aesthetic space, we have them in some capacity on our team. Um, let's get into exactly what this program is about as far as OD Immersion goes. We've broken the program down into three progressive tracks: logistics, language, and launch. And when I say progressive tracks, you don't go straight to launch, which is treatment. You start off in logistics. And here's the reason why. You can read some of these. I'm not going to go over every one of them. But when doctors bring these into their office, they often underestimate some of what needs to be done in the background to actually make this work. What does your flow look like? What does your staff look like? What does your pricing and packaging and positioning look like? All of these things need to be taken care of before you start pulsing that device. Do you have patient education forms? Do you have pre and post consent forms? What are your ROI targets? Does your staff know how many patients you need to convert in a given month to actually hit your targets? These are what we call logistics, and these are all the things we do in typically the first 3-4 weeks when we start working with someone. And I would say logistics is probably one of the most important parts. It's really setting the foundation of your dry clinic. So from here, we continue on and build. We move into what we call the language track. This is a very interesting part. This is where we train your team and actually talk about the language of conversion. And I'll give you an example of that. Let's say you have a patient, you're doing a dry eval, and you tell that patient, hey, there's 3 layers to your tears, right? We have the oil layer, the aqueous layer, the mucin layer. Your meibomian glands are clogged. What we need to do is use you've already lost them, right? That is too much complex information for a patient to handle. And immediately, if you look at some neurofinance principles, what we're trying to do here initially is make the patient feel comfortable. And when we use those complex terms, which to us are simple terms, but to a patient, those are very complex, their guard is already up. So this is the part of the program where we really teach people the techniques and the strategies. What words do you use to make that patient understand the value of what you're offering, the significance of their condition, and there is some education here as well for those docs who are not accustomed to reading my biographies, for those docs who really aren't that well versed on tear film. Like, we all know what dry is, right? We're all doctors, but some docs are unfamiliar with biofilm. What does biofilm mean? What does it look like? Even when I first came out of school, I remember the days of dry eye, meaning you look at the cornea and you see if there's any keratitis there. Well, my understanding and my viewpoint of dry is completely different now. I see that keratitis, and my first question is, what is the underlying cause? Where did that start? And let's start backtracking, right? And find out really where's that coming from. So this is how to counsel patients. This is, you'll see this little term here called biomes. This is everything that IPL does in one little acronym, so you have it in your mind. So when you're explaining this to a patient, you can go into some of this. Also, the steps to conversion. When we do team training, we go through, here is how to convert a patient. And then we get into the fun part. This is the launch track. This is where we actually go over, for your particular device, what are your protocols? How do you treat dry? How do you treat rosacea? How do you treat chalazion? Do you need corneal shields, or should you use stickers? Can you use goggles? Do you need ultrasound gel, or do you need lotion? Because it gets really confusing. Some of these devices out there, as it relates to something, for example, like radio frequency, use ultrasound gel. Others need to use lotion. And if you get those confused, you can have some pretty significant adverse events. And that is one of my issues, as I mentioned in the beginning, with going on social. Unless you know exactly what device that doctor who's giving you feedback or giving you advice has, it's hard to know if you can do the same thing. So you really have to be cautious with some of the device you get. There's some great information out there, but you do have to be careful. But this is where we get into or OSD protocols, doctor and team scripts. Knowing the precautions and contraindications is very, very important. And you will also start to move a little bit into, for those who are interested, into aesthetics as we get into the launch track. We also have, and it's a big part of our training, what's called the ODI portal. There's protocol guidance. You can see the screen or the image up there in the top right. I didn't put a video in here. I probably should have, but we literally walk you through step by step with every single modifiable factor on that device, how to treat a patient. How do you treat rosacea? How do you treat just MGD? We will get into some of the aesthetics for those people who choose to, but really what we're focused on is dry eye with this initial training. There's patient presentation example videos. One thing we're really, really excited about is something that we've launched this year, which is called communities. And that is where we group people together who have the same devices. And instead of doing one-on-one calls, which we do with everyone, we do group calls, because we can learn from feedback from other similar practices. What problems are they having? What's working for them? And so we have regularly scheduled group calls in our communities. It's also a very safe space for posting questions. Sometimes on social media, which again, I have a love-hate relationship with, but sometimes you go on there and you post a question, and some of the responses are not as kind as they could be, right? You're a doctor, you should know this, those type of things. And so this is a really safe space where you're posting a question into a group of people going through the same thing that you're going through. Again, we do weekly video emails, and these can be on these are on everything OSD related. Sometimes, like last week, mine was on Lacrophil. The week before that, it was on Oxervate. The week before that, it was on lentiginase, which is an aesthetic issue. And then we also launched this year our OD Immersion app. It's now available on Google Play and on the App Store. And it is our full ODI portal in the palm of your hand, all the videos, all the protocols, all the training that you need right there. So we're very excited about that, and we're continuing to advance this program as much as we can to make it as seamless as possible. We do live calls with industry experts. So these are all typically an hour sessions. But if there is a dry expert or an aesthetic expert, so sometimes it's dermatology, sometimes it's a laser specialist, sometimes it's a plastic surgeon, but we try to keep more of it dry related. And we focus in on one specific topic. I mean, if you look at the top right, Peter Pham, Dr. Pham invented Zocular. So we talked to him about biofilm and Demodex. And so we can just really dive deep into a very specific topic on these calls. And we try to find really well-known dry people to do this with, people who are deep in the space, actively seeing patients, and they're great calls to really learn on. These are all also in our portal for people to watch anytime. We have forms. Forms, you don't need to go out and create these yourself, but they are things that are needed in your office. So you want to provide that patient IPL instructions and IPL education, reminders. Hey, have you started any new medications that might be photosensitive medications since I saw you last? Makeup. If you asked me 5 years ago if I'd ever know a thing about makeup, I'd say no. When you start getting deep into dry eye, you're going to have to know a little bit about makeup, at least what are the toxic chemicals that contribute to gland loss. And so when I tell a patient, hey, you need to really stop this waterproof mascara, their next question to me is, okay, I will, but what do I use? So we have sheets already made up with eye safe mascaras, eyeliners, lash serums, makeup removers, all these things you can think of. There are take home sheets for the patient, there's consent forms, there's brochures. So, really, anything you can think about, we have it covered. We also review website and social. So, when we go on someone's website, what are we looking for is, do they have a validated symptom survey on there that patients can fill out? We receive these regularly. Patients who aren't ours, but they found our website, they'll fill out a symptom survey. That now gives us the opportunity to contact them. When a patient or when patients go to your website, do they know that you offer these advanced services? Do they know that you are a dry specialist when they go there, or do they not? Social media. We evaluate all those things, and there is a marketing component to OD Immersion. It's not part of our main program. It's something that you can opt into, but we are able to provide marketing assets to those who need it. Same thing with social media. First thing I do is go to someone's social site, and if I don't see any information about dry eyes, and the last time they posted was 8 months ago, and they're concerned that they're not having many conversions, well, we have to look at all these details that are contributing to their success or lack thereof. So if we just kind of wrap this up, I want to leave some room for questions. Here are some of the critical elements for success. Decide what type of clinic you are in terms of, are you going to be presenting from the comprehensive exam, or are you bringing them back for a dry eval? Establish your screening protocols. Again, on something like the keratograph, you can decide what tests you want to do, put them in the order that you want, so you're creating that story for the patient. Prescribe objectively. One of the things that I learned from my consulting partner, who was very direct, is say what you see. If I have a patient who's severe, I'm not going to jump around the issue. I'm going to say, Miss Jones, what I'm seeing today is that you have severe meibomian gland dysfunction. Here's how that's going to impact you on a daily basis, and here's the solution for it. And then you can track progress again with things like your mybography and your tear breakup time, whatever device you have to do that. One fine point I want to put here is mybography is used as a diagnostic tool. It is not used as a gauge for success. And what I mean by that is, if you do mybography on someone and you do 4 IPL sessions and you bring them back and do mybography again, it's probably going to look the same. So really, and don't think that the treatment was unsuccessful if it looks the same. We expect it to. You're gauging the patient's symptoms. You're grabbing that really crucial information from the patient. What is their treatment goals? What do they see as this being success? Mybography taken again a year later, 6 months later, yeah, you might see some change there, but you do not need to do this at every single visit. So clearly defining your clinic type, identifying these essential elements, communication in a very direct way with the patients is important. And these will all give you the strong foundation for creating a successful dry eye clinic. I want to talk really quickly here about Darwin, because it is a very powerful, I think it's probably the most powerful device out there as it relates to IPLs right now. If you're looking at IPL systems, you want a filtered system. There are some companies out there who have non-filtered systems who claim that they can treat everything. Well, the point of a filter is to be able to access different layers of the skin. And so, particularly if you're treating aesthetics, you want to be able to target those different layers. You cannot treat everything with one filter. On the Darwin, we do have Toyo's presets in there. Most of you are probably familiar with the Toyo's protocols. If you're not, please go look it up. There's preset Chalazion protocols, and you have 3 light guides to choose from, which allows you to get into the nooks and crannies around the eyes that sometimes these devices who have one light guide, you're not able to do that with. Um, some other features is Pulse Train. If you're not familiar with Pulse Train, I'm not going to explain it all in great detail right now, but most reputable devices are going to have single, double, and triple pulse technology. Now, an interesting, and this allows you to control depth, control how it feels to the patient, control your energy levels. There's a lot that goes into that. But one unique feature to the Darwin is it has what's called a toning pulse. And especially if you're new to IPL and you have a patient in for their first session, what you don't want to do is blast them. You don't want it to be uncomfortable because the chances that they're going to go home and tell their friends, hell, that was a nice treatment and it actually felt okay. That's not going to happen. A toning pulse allows us to prep the skin to a certain extent in a very non-painful way for some of the therapeutic treatments that we're going to provide to them after that first pass that we do on their face. So the toning pulse, really unique feature. All of these parameters that you see on the image there are modifiable on this device. There are a lot of devices out there that you can control the fluence, but you can't control the pulse. You can't control the delay. You can't control the pulse train. So it is a very it allows you to really get into granular treatments as it relates to IPL. So that's all I have. If you guys want to contact us, there's our website, which is going to it's in the process of being updated. So it's going to look extremely different 2-3 weeks from now than it does now. Phone number, that's where you can text or call. And then if you scan that QR code, it's going to allow you to schedule some time with us. And it's a non-committal time. It's not a pitch. It's us sitting down and saying, hey, tell us more about your practice. How many people do you have? What's your flow look like? Is this something that you really want to get into? And that is it, guys. So thank you. And if there's any questions, I am open to questions.
Shane, that was a great job. We have a lot of good questions. The good news, though, is you answered the vast majority of them in your
Awesome.
talk. But there's a couple things I wanted to bring up and see if you can comment on.
Sure.
You mentioned about meibomian gland expression after IPL.
Mhm.
Can you talk a little bit about how you do it and how often you do it? Do you do it with every IPL? Do you do it every other? Or tell me about your routine with expressing glands.
Great question. And there's a lot of varying opinions out there on this. And even if you look at the top dry eye doctors around the country, some of them are doing it after every session. Some of them are doing it after the 4th session. So it really varies. What I'll say is if you look at the studies, expression is done after every IPL. Does that necessarily mean that you're going to get the best outcomes by doing that? Not necessarily. So here's the way I'm going to answer that question, Bill, is it depends on your practice. It depends on your device. It depends on your patient flow. It depends on, are you doing the treatment? Is a technician doing the treatment? It depends on, do you have a spa room where you have to now walk that patient into another room that has a slit lamp to do it? So there's many factors that come into this. I will tell you how we do it, and what we've found after doing it every way you can imagine has worked for us and for my clinic. And I'm not saying this is the way to do it. I'm saying it's different for everyone. But what we do is at our first visit is IPL. Our second visit is a combined treatment IPL and RF. What we've found is that expression is much, much, much better after a thermal treatment using something like radio frequency, which the Darwin comes with, right? That's part of the system, is you don't have to worry about the skin cooling down as quickly as you do with just IPL alone. So in my office, we have spa rooms, patients laying down, we do these treatments. I'm not feeling the need to now rush them into my slit lamp room to do expression. We clean them up, we get them over there. I do expression. It's beautiful expression. I know that's not a direct answer, and unfortunately, that's a lot of where we're at in the dry space right now. Is it depends. Um, on certain devices or on certain patients, if they have really, really bad rosacea, for example, well, we usually hold off on doing RF on them too soon because it can actually irritate and inflame the rosacea. So on those patients, I'll express after every visit. Sometimes I don't express and my technician will and record it so I can go in and see it. And again, there's practices who do it all different ways. There's no solid consensus on whether it needs to be done after every visit or not. So again, if you're looking at the studies and you want to follow those studies, then yes, expressed after every visit. Here's something else I'll say. If you're following the studies, then you probably shouldn't be using corneal shields because none of the studies included corneal shields. A lot of docs feel like they have to use them on every single patient. I use them. I used to use them probably 95% of the time. And then I went back and started reading the studies and realized none of these studies were done with corneal shields. So when do I use them now? For chalazion. Otherwise, it is a much more pleasant treatment for the patient. My outcomes have not changed at all in terms of the results I'm getting from using corneal shields versus not on a normal MGD patient. So I know I answered a different question there, but I hope that helped. And again, I'm happy to have this discussion further because it is somewhat up for debate, and probably every doctor you talk to is going to have a different opinion. My thoughts are coming from my practice as well as working with docs all over the country, Canada, all over the place, and kind of how I see people doing things and getting good results.
Before I leave this topic, Shane, I know my patients comment to me about how comfortable IPL can be and how comfortable RF can be, but often how uncomfortable the last part is, the expression part. Have you found a tool that you find it is effective and but yet still comfortable to
Yeah,
express?
I'm going to open up a whole new can of worms here, Bill, which is there's I'll tell you my thoughts on expression. My thoughts on expression are I do not need to torture this patient and try to express every bit of congested meibum that they have, right? What I want to see now, if you think about what should cause meibum to be expressed is a normal eyelid blink, which is around, what is it, zero point 0.2 or zero point 0.5 psi. It's almost
Right.
no pressure, it's very little. So when I'm expressing, I go in and I use an Oculus lid stick and
Yep.
I press a little bit and I see, do we have movement? Do I have some oil flowing out of there? If I get some toothpaste looking stuff coming out, yeah, I'll press a little bit harder. But my goal is not to express all of that meibum out of there because the point of them going through the IPL sessions is to improve the quality of those oils. So at the first session, maybe they're still a little congested. By the fifth session, now I can press gently. I got some pretty good oils coming out. And so, yeah, I used to squeeze the heck out of it, and patients didn't like it. And now my thoughts on that have changed a little bit in terms of do I really want to release all this toxic material onto their surface? Or am I doing this for the purpose of seeing where I'm at in treatment? And that's where I've landed. And so my expressions are not nearly as aggressive as they used to be.
Excellent. Yeah, I think there's a lot of people moving that direction. I've witnessed some people doing their expressions, and it's almost painful to watch.
Yeah,
Never
yeah,
mind,
yeah.
never mind to be the patient.
They
So
make
I think
they
we
make they
have time
make. I
for.
will say they make some for some very cool social media posts, right? I mean,
It's
when you
true.
when you get that nasty expression coming out, that's something you want to post. But you got to keep in mind, you're the patient. It's not very pleasant.
So I want to close with one interesting concept you touched on, but I think it's worth elaborating on, and that's IPL and RF as a first line treatment versus a last line of I've tried
Yeah.
everything else and now I'm going to do. Can you just talk a little bit about the concept?
Oh, absolutely. So when I talk about this, I like to go back to what a lot of us refer back to in terms of what should we be doing for a given patient at what grade level they're at. So if we look back at the DEWS 2 study, if we look at stage one, DEWS 2 is basically use some artificial tears, drink more water, use some heat, right? It's not a whole lot. It's not meant for patients who are really symptomatic. When we move into DEWS 2 study stage 2 treatment, IPL is right there in stage 2. It is on par with our immunomodulators. It's on par with our anti-inflammatories, our Lotemax, our Isuvis, our Durezol, all those things. And so a lot of people are under the impression that IPL is reserved for advanced cases. I will say that is that I understand that, but IPL really should be used early on in treatment so that that patient doesn't get to an advanced stage, right? I don't want to get to the part where the patient's at stage 3 and stage 4. If you have some gland loss and you have some congested meibum, I'm doing IPL on you. I think it is the best treatment. It's the strongest thing that we have in our toolbox. Does that mean I'm going to not use some of those other kind of traditional drugs and drops? No, I'm gonna probably use some of those also. It depends on the case, but simply stated, IPL should be done early in the process. So think of when you would use a steroid, when you would use an immunomodulator. That's right where IPL comes into play. And that's not the opinion of OD Immersion or myself. That's based on TIFO's DEWS 2 study, which was very powerful to see because we knew this for a while, but it provides a lot of clout to IPL and the power that it provides to our patients.
Awesome. That's a great answer. Shane, thank you so much for sharing your knowledge with us tonight. It was really a very enlightening webinar, and I think a lot of people are going to be listening back to it because there was so much there to absorb. So thank you so
Great.
much, and thank you all for attending tonight, and have a great evening, everybody.
Thanks, everyone.